All right, guys, let's go. Essentially, this morning we're going to talk about growth and development. And essentially, in pediatrics, growth is really what it's all about. So childhood is really that time of growth. Now, when we talk about growth, we're really talking about all aspects of the development of the individual. So we look at our cognitive growth and development, we look at our neuromotor development, the ability to move from a newborn who can't turn over to individuals who are doing gymnastics at the Olympics. So we look at cognitive neuromotor development, we talk about our physical growth, and we talk about our social and emotional growth. So we go from our little 1-year-old who's still in diapers and who basically doesn't know how to share, hopefully medical students who know how to share and work as a team. And then our emotional growth is something that we probably always continue to develop as we move through our life. But today we're really going to concentrate on the physical aspects of growth. And as you can see from our slide, growth is dynamic, it's multifactorial and a complex process, and really results in the two-cell zygote achieving its full inherent potential. Anytime we deviate from a normal pattern of growth, this may be the first indication of a disease process, either endocrine or non-endocrine. So in pediatrics, we always want us to be measuring children's heights, weights, head circumference. I'll go into that in a little more detail from visit to visit, because those are the parameters of physical growth that we need to pay attention to. And when we evaluate a child's physical growth or anthropometry, we always do this in the context of normal standards. And this has led to the development of growth charts from both cross-sectional and longitudinal population data. And these charts you should be very familiar with from your junior clerkship. So we have our various height for age, weight for age, height velocity, and body mass index charts. And then we have for special conditions such as Turner's syndrome, achondroplasia, and Down syndrome or trisomy 21, we have special growth charts for those. So we're going to now switch and actually look at some of those charts and how we use them. All right. I know you guys are seeing my growth chart, right?
Yes, we are, Doctor.
All right, perfect. Now we have basically two sets of charts. We're seeing our percentile charts and our Z-score charts. And so our percentile charts are the ones you're looking at now. And these are the CDC charts out of the US. You have Tanner White House charts, and you have the WHO, World Health Organization growth charts. So you'll see different growth charts, and they're pretty much similar. It's just that the population base, which has actually led to the development of these charts, is different. Now, as we have here, we have a birth to 36-month chart, but let me just go up a little bit. Right. Right, so we're seeing birth to 36 months, and the and the top graph is length, and the bottom graph is your weight. So here we have the 50th percentile, and then these charts, which are the CDC charts, go to the 97th and the 3rd percentile, and the 97th and 3rd are 2.5 standard deviations from the mean, okay? And your mean is the 50th percentile. So when we look at an individual and they're on the 50th percentile, what does that mean? All it tells you that in relation to the population, a child on the 50th percentile, they, in terms of length, 50% are taller than them and 50% are shorter than them, all right? If I'm on the 97th percentile, tells me that I'm taller than 97% of individuals of my age. And if I'm on the 3rd percentile, means 97% of individuals are taller than the child, and that child is only taller than 3% of the population. And that goes to the same thing for our weight, and the same. So a percentile does not tell you if an individual is growing. It only tells you whether an individual, where that individual falls in relation to the population, okay? So as we go through our charts, so this is height for age, starting at birth to 36 months, and the lower chart is weight for age, and these are boys. A similar chart for girls, 0 to 36 months. And then we have our head circumference chart. Now, let me just go back a little bit. Right. Now, for anybody to know if we are growing, we have to have 2 points on the curve. Okay? And the slope of the curve is indicating the rate of growth. So if I have somebody at, let's come down, 12 months, and I have a point here, and then at 15 months, I have a point here, indicates that the child is following the slope of the curve, all right? Remember, the slope is height change over weight change over time. So height velocity is length, change in length over time, and that is equivalent to the slope of the curve. So even if I have a child below the 3rd percentile, or when I'm plotting, they're following the slope of the curve, then their growth velocity is normal. So what's important is 1 point indicates where you fall in relation to the population. 2 points give you the growth velocity, which is the indicator of growth. All right? And the growth velocity is, units are centimeters per year for length, and kilograms per year in terms of weight. All right, so let's move to let's go through these charts. And so the head circumference chart, same sort of thing. We're recognizing our percentiles, 50th to 97th, 50th to 3rd. And if you're looking at the shape of this curve, you notice the first year, it's pretty steep, and then it starts to level off. So that tells you that your head circumference velocity is very quick, fast in the first 6 months, slows down in the second 6 months, and keeps slowing down. And you, in fact, achieve 2/3 of your head size by the time you're 2 years of age. So this is critical for us to continue to follow the head circumference in children in the first year of life. If we have a head circumference velocity that is increased, And so the child is doing that and crossing percentiles, then we worry about this child could have hydrocephalus. Okay. On the other hand, if you have a child whose head circumference velocity is falling off the curve, then we worry about what's happening in terms of brain growth and why is that brain growing, not growing. Could there be some developmental anomaly in the brain that is resulting in poor brain growth and therefore poor head circumference velocity? Okay. And this chart really is looking at the same sort of thing for girls. Okay. And then we look at our height for age in children. And here we go from 2 to 20. And when you get these curves, it's important to just have a look at the shape of the curve. And you'll recognize that somewhere between 9 and 12, 9 and 14, there's a belly in the curve as indicated there. And that's indicating that there's a slowdown in growth velocity or height velocity just before you come to puberty. Between the ages of 2 and 9, your growth velocity basically is pretty constant, and then it falls off just before you go to puberty. And that is the body sort of storing up and slowing down before the final growth spurt. And here we see the velocity increasing again as you go through puberty to achieve your final adult height. You'll also notice that in terms of weight, we all pretty much are pretty close together in terms of weight in our younger years, but as we get older, certainly depending on our body habitus, you'll recognize that there's a diverse change in our weight. Same sort of thing for girls. We're looking at the shape of the curve, and we're recognizing that belly just before puberty. Now, this chart is essentially our body mass index chart, looking at it from boys from 2 years to 20 years. And what we're seeing here is we recognize in pediatrics percentiles which relate to being overweight. So any child above the 85th percentile is considered overweight, and any child above the 95th percentile is considered obese. And you recognize, once again, just looking at the shapes of the curve, that at 2 years, your BMI starts to fall. And somewhere between 5 and 6, it rises again. This is where you lose your baby fat. And children who don't lose their baby fat, and say you're on the 50th, and you just keep going, you're going to end up in the obese, overweight, obese range. So we expect between the age of 2 and 4 for your BMI to fall, and mathematically that indicates really that your rate of height change is greater than your rate of weight change. And remember the calculation for BMI, height in meters squared over weight in kilograms. And so it's important to follow these charts so that we in fact recognize, not just looking at kids and saying, okay, he's a normal weight, because we've gotten accustomed to people being, as we say in Jamaica, on the chubby side, but we've got to classify them. Are they overweight? Are they obese? And over the 97th percentile, we can call them super obese. Okay? So one of the important things as we leave these growth charts is that we need to be very familiar with plotting and using these charts, understanding what it means. And I'm going to just go here. Somebody on the 97th percentile at 7 years, okay, we can't say whether they're growing or not. But if in fact, when we plotted them before at 5, they were here, way above the 97th, and at 7, they're on the 97th. If you notice, that's a flat line, so there has been no growth in the last 2 years, and that's a problem. So the growth velocity is flat, and the question is, why is this child not growing? Because children are always growing, so they're always following a growth curve. Once you stop following the growth curve, then that's an indicator that there's a problem. Okay, so we'll stop sharing that, and let's go back to my... Any questions at this point? I see a little question. Okay, no questions at this point? Okay, I guess not. So let's go back to our slides. Okay. Now, as we have this child in front of us and we're assessing their anthropometry and their growth, we need to collect our data so that we can use it on our growth charts. And obviously, accurate collection of data is important if we're going to come to an appropriate conclusion or assessment. Now, when we define a child who's short, we're saying that a child who falls below the 5th percentile is short. And that's how we're defining short stature. We need to measure this accurately. So when we look at a child who's under 2, we don't get them to stand. They're really, we do the supine length, while over 2, we do the standing height. So all kids under 2, we should be doing a supine length, and over 2, we do the standing height. The position of the child is critical, so we need the head, and unfortunately, I'm not in front of you to show you. We do the position of the head if the child is using the Frankfurt plane, where a line connecting the outer canthus and the auditory meatus is perpendicular to the long axis. So the head is in that position in the Frankfurt plane. The thoracic spine, buttock, and heel are touching the stadiometer. Actually, let me come out of that for a moment. Let's go to me. So as you're seeing, you're drawing a line from the outer canthus to the tragus. So that's that line from the outer canthus to the tragus, and that line must form 90 degrees to the vertical, okay? And that's important so that when everybody's measuring, that we're doing the same thing. And remembering that the spine, buttocks, heels slightly apart are against the stadiometer. And I think, if I remember correctly, in your junior class, you guys had a session where you actually went through using the stadiometer. All right, so let's go back to my my screen. Right. All right, so the first thing we measure is we measure the child's length or height, and then we go to our body proportions. And we recognize that our body proportions change with age and growth. And so what we measure is the upper segment and the lower segment. The upper segment is measured from the crown of the head, okay, to the symphysis pubis, and the lower segment is measured from the symphysis pubis to the heel. In the newborn period, the upper segment to lower segment ratio is about 1.7 to 1. So if you're in a nursery and you're seeing those babies, they're all head and trunk and very little feet. Most of your subsequent growth increases differentially in your long bones compared to your head and trunk. And we've talked about the head, 2/3 of that head having been achieved by 2 years of age. And then most of your subsequent growth is now happening in your long bones. So your ratio at about 4 years goes to 1.4 to 1. Just before you hit puberty, your ratio is about 1 to 1, upper segment to lower segment. And then as an adult, you're less than 1. Now, we recognize that a number of abnormal growth conditions may be associated with what we call disproportionate growth. And so when we look at our dwarfs, such as our achondroplastic dwarfs, who have short limbs, their short limb dwarfism, you find that their upper segment to lower segment ratio will be increased for their age. So they may be 9 years old, and instead of having a 1 to 1 ratio, they're having a 1.5 to 1 ratio. Okay? So we recognize those abnormal ratios may be seen in certain skeletal conditions, such as skeletal dysplasias like achondroplasia. The other thing that we will measure in looking at body proportions is the arm span or wingspan. And that is measured with the hand stretched out, measuring from fingertip to fingertip. And the normal arm span or wingspan is plus or minus 5 centimeters from your height. So we recognize in patients with Marfan syndrome, they may have an arm span or wingspan which is greater than 5 centimeters from their standing height. On the other hand, our achondroplastic patients or patients with skeletal dysplasias, their arm span may be significantly shorter than their standing height, as they have problems in limb length. So what we want to do, we've done our lengths, we've done our body proportions, and the next thing that we look at is our skeletal maturation or bone age. And our bone age really is looking at the rate of maturation of our epiphyses. And what we do is our ossification. And what we do is an X-ray of the left wrist. And if you X-ray the left wrist of a newborn, you won't see any calcification or ossification, because the bones of the wrist at that stage are all just cartilaginous. And as you grow older, you start to ossify the carpal bones, and the rate of ossification indicates what we call your bone age. So we can use that X-ray of the left wrist to look at what the child's rate of ossification is, and therefore their bone age. If I may have a patient who has precocious puberty, and the rate of ossification has been increased due to their pubertal hormones. So you may have a 6-year-old girl with precocious puberty who has a bone age of, say, a 9-year-old. On the other hand, I may have a 9-year-old who has a chronic disease, such as heart failure or ulcerative colitis or Crohn's, and who fails to thrive, and their bone age may be, in fact, delayed. So that child may have a bone age of 6 because of their chronic disease. So it's really helpful when we're looking at growth to see what the skeletal maturation is. And we recognize that the rate of maturation differs between males and females. So we have to compare boys to boys and girls to girls. And we can only use these standards for normal children. So I can't do a bone age in a patient with, say, Down syndrome or a patient with any other chromosomal abnormality. So I can't do it definitely in the babies or the children with skeletal dysplasias who have a problem with their ossification centers. Then the next thing that we look at is the genetic contribution to your child's height. Okay? We all are born pretty much around the same length, somewhere between 47 and 52 centimeters. However, as adults, our heights vary. And so we, in fact, can make an estimation of where your height should be by calculating what is called the mid-parental height calculation. Okay? And that actually allows us to see where you fall, where your percentile is compared to what we expect from your parents' heights. So for boys, we do the maternal height plus the paternal height divided by 2. And we either add 6.5 centimeters if we're working in centimeters, or 2.5 inches. On the other hand, for girls, we do the same thing, but we subtract 6.5 centimeters or 2.5 inches. And at this time, all right, let me ask, does anybody want to give me what their parents' heights are? Anybody knows their parents' heights? Does anybody have parents? All right, since everybody's been shy, let me ask somebody then. Kevin Fraser, you know your parents' heights?
No, Doc.
Okay.
Morning, Doc. I'll just go ahead.
All right, Cabrina, tell me your parents' heights.
5'1" and 6'1".
All right. All right, so what I'm going to ask the group to do is to calculate the mid-parental height for Cabrina's parents, all right? So what the mid-parental height tells us is that if Cabrina's parents had 100 girls, then the mean height of those girls will be the mid-parental height, okay? So let's run this through, and I always remind the groups that there's 12 inches in a foot. And so at 6 feet 1 inch, Sabrina's dad would be 73 inches. All right, so let's do that calculation. It's a GSAT calculation, and let's hear what the mid-parental heights are. And when you got it, you can just put it in the chat. Are you guys being shy to put it in the chat? Okay, now Tanya, were you working in centimeters or inches?
Centimeters, sir.
No, you can't work, no. Because 60.5 centimeters is about, that's really about 20 inches. So you got to do it in inches.
Okay.
Like remember, I mean, if you're doing it in centimeters, you got to convert 6'1" and 5'1" into inches. All right. All right, Racine, you're a little bit off. Right. Yeah. Yeah. And you got it right. So basically, you got to get that ½ inch in there, right? So we'll move on. So essentially, boys will be 5'9½", and girls. So that's the mean height, and girls will be 5'4½". Sabrina, how tall are you?
I'm 5'2½".
Okay, right. So let me go to my, let's just go to my growth charts here. So what we're going to do is we're now going to plot this on the growth charts. All right, so here we go. Right. So essentially what we then do, and we're using girls. So 5'4½" or 64.5 puts you directly on the 50th percentile. So we have a mid-parental height of 5'4½", and it gives us a mid-parental height percentile on the 50th percentile, okay? Now, we can actually have two standard deviations on either side of that is 2 inches to give us a range. So we can go up to 66.2 inches to 64.5 to 66.5. So that puts us just above the 75th percentile. And 64.5 minus 2 puts us to 62.5. All right. And so Cabrina now falls just at the lower end of the range. The 62.5 is on the 25th percentile. So when we in fact look at Cabrina's family, her parents, if they had 100 kids, 100 girls, the mean height would be on the 50th percentile, but they could have girls on the 25th and girls on the 75th. So that gives us a band where we expect the girls in Cabrina's family to fall. All right? And Cabrina, do you have sisters?
No, I'm the only child for my parents.
Okay, so
I have a brother, but we have different fathers.
Okay, all right. So that's the plan. So so we expect for that family that this is where the girl should fall. Now to end up here, it means you've got to generally follow the curve all the way up. Okay? So that allows us to be able to compare a child at 7 as to where they should be. So if I have a child here on the 3rd percentile, and I expect them to be between the 25th and the 75th, then they are out of keeping with their genetics, okay? The same thing up here. So I expect that all the girls from that family are going to fall between the 25th and 75th percentile. So this gives us an idea of where our genetics puts us. So ladies, depending on what height kids you want, you have to decide on what height guys. So in fact, Cabrina's mom really picked a tall guy to give her the benefit of getting some height. Okay, let's go back to my other slides. Right. So just quickly recapping, we've looked at measuring the actual length or height of the child. We've looked at the body proportions, upper segment, lower segment, and we have looked at the bone age, and then we've got an idea of where the genetics would put that child. All right. I'm going to go back to the graphs in a little bit, but we're going to look at some normal variants of short stature. But most people who are short are normal. And we have what we call our genetic short stature and your constitutional short stature. Now, first of all, to be defined as normal, you must be growing at a normal growth velocity. So you must be following the curve. Whether you're below the 3rd percentile or above the 97th, you must be following the curve, okay? So when we look at somebody with a genetic short stature, we recognize that their growth velocity is normal. When we do their bone age, they may be 7, which is their chronological age. And then when we look at their bones, they have the bones of a 7-year-old. All right? When we look at their height percentile, right, they may be on the 3rd percentile or the 5th percentile. And when we do that band, looking at the mid-parental height percentile, they fall within the band. So we saw that Cabrina, even though she was at the lower end, fell within the band, okay? On the other hand, we have somebody who's constitutionally short. First of all, they must have a normal growth velocity. But when we look at them, they're 7 years old, but they may have the bone age of a 5-year-old. And then when we look at compare their actual height percentile to the mid-parental height percentile, we find that their height percentile may be on the 5th percentile, but their band should be between the 25th and 75th. So their actual height percentile is not comparing to their mid-parental height percentile. All right? Now, the next thing I have to define for you is a height age. And so I'm going to go back to my charts. And we're going to define height age, which is different from height for age. All right. So this is a height for age chart. So you have the height and you have the age. All right. So in the height for age chart, somebody may fall on the 50th or 97th or 75th percentile. Now here's the definition, height age. And y'all get your pens and you write this down. The height age is the age that a child of that height would normally be. Let me repeat it. The height age is the age that a child of that height would normally be. So, let's look at this. If I have a child of 7 and his height is 123 centimeters. So a child of 123 centimeters would normally be 7 years old. However, if I have a child at 5.5 years and he's 123 centimeters, he has the height at 5.5 of a 7-year-old. So what we do is we take the child's height and extrapolate it to the 50th percentile. So a child of 123 centimeters, who is 5 years old, has the height of a 7-year-old. On the other hand, if we come over here, I have a child who is 9.5, but he's 123 centimeters. So when I extrapolate him back to the 50th percentile, he has the height of a 7-year-old. So the height age is the age that a child of that height would normally be. Any questions? Everybody following?
Excuse me, Doc, can you go through that one more time, please?
All right. So I have a child of 123 centimeters and he's 7 years old. He falls on the 50th percentile. However, I have a child of 123 centimeters height, but he's only 5.5 years old. Right? So at 5.5, he's 123 centimeters. So therefore, he has the height of a 7-year-old. On the other hand, I have a 9-year-old who is 123 centimeters. So when I extrapolate him back to the 50th, I find that for a 9-year-old, he has a height of a 7-year-old. Okay?
Okay, so we're comparing for the height age, we're comparing the whichever age group has the height in the 50th percentile?
Correct.
Okay.
So if I had a child who is 8 years old and he is called 140 at 8, he actually has a height of, and I extrapolate him over to the 50th, that's the height of a 10.5-year-old.
Okay, and then the height for age is just whatever percentile that child is in for their age?
Correct.
Okay, thank you.
Okay. So let's go back to our slides. Right. So just to finish this up, so in our genetically short person whose growth velocity is normal, who is 7 years old, whose bone age is 7, whose height percentile falls along the band with the mid-parental height percentile, but he has a height age which is less than his bone age. So at 7, he has the height of a 5-year-old. So therefore, his height age is not equivalent to his bone age. All right? On the other hand, when we look at our constitutional kid, who's growing at a normal velocity, who's 7 years old, he has the bone age of a 5-year-old, his height percentile is actually less than what his mid-parental percentile should help us with. But when we look at his height age, he has the height of a 5-year-old, which is equivalent to his bone age. Now, you all knew these kids because they're in high school with you. They're usually boys with a constitutional short. And in 4th or 5th form, they look like they should be in 1st and 2nd form. And then somewhere through 6th form, they shoot up. Because these kids with constitutional short stature also are going to have delayed puberty. So they're going to go into puberty a little bit later. So their pubertal growth spurt is going to be later, and so they're going to catch up a little bit later. All right? Okay. Now let's look at some of the factors required for growth. Now, none of you have built any houses, but if you're building anything, you always start off with a plan of what you want to build, okay? If you're going to bake a cake, you have a plan of what's going to be in that cake. Now, when you're kind of building humans, your plan is in your chromosomes and hence your genes. So the first thing that we need to assess in somebody with growth challenges is there a normal chromosome status, and is there a normal gene status? So we may have a child with Turner syndrome who has exochromosomes, or we may have a child with skeletal dysplasia who has normal chromosomes but abnormal gene status. So for normal growth to occur, you need to have a normal chromosomal status and a normal gene status, okay? And having had that, you then need to build this person. So you need to have available the building blocks. which include energy, protein, water, micronutrients. All of that stuff must be available. So if you have a child who has a problem with substrate, for example, a child with malnutrition, or a child who, say, has a malabsorption problem, then we're going to have problems with having the building blocks for normal growth. And then growth is facilitated by your hormones. So you have insulin, you have growth hormone, and we recognize insulin and insulin-like growth factors, especially insulin growth factor 2, is important for your intrauterine growth. Growth hormone important for your extrauterine growth, as is thyroid hormone. And thyroid hormone is not only critical for your physical growth, but it's important or critical for your brain development because it facilitates a process in the brain called arborization. And arborization is where you actually increase the interdendritic connections between your neurons. Just like increasing all the connections between you have lots of computers and you're connecting them together, you increase the power of your computer. So that process of arborization is important and facilitated by thyroid hormone. So children with hypothyroidism at birth or congenital hypothyroidism, then the challenge will be to diagnose them early and to replace the hormones so that they can have normal brain growth and development. And then finally, we're looking at absence of disease states. So any chronic thing, whether it be chronic heart disease, heart failure, or cyanotic heart disease, GI disease, renal disease, whether it be renal failure or nephrogenic diabetes, any disease state is going to impact on your normal growth and development. Okay? So it's important for us when we have kids who have growth issues that we're paying attention to all these things. And we can also classify them as primary growth abnormalities or secondary growth abnormalities. In primary growth abnormalities, we're looking at things such as chromosomal abnormalities that I mentioned, gene abnormalities such as the osteochondral dysplasias, and then you look at things that impact on intrauterine growth. Now remember that your first trimester is cell multiplication, your second and third trimester is cell hypertrophy. So situations where you have impact in your first trimester is going to have a more detrimental consequence on your postnatal growth than something happening in the third trimester. And then we look at the syndromes such as Russell-Silver, which is a form of dwarfism, Noonan syndrome, which is male-Turner syndrome, Prader-Willi, which is another syndrome with obesity and short stature. Then we have the congenital infections, all the torch group of infections. If we have placental issues, that will lead to intrauterine growth abnormalities. We look at maternal disease, such as maternal sickle cell, severe maternal diabetes, cardiac disease, all can impact on the fetus and result in intrauterine growth problems. And then we look at drug ingestion. So whether drugs that we give to patients, such as we have certain syndromes, fetal dilantin syndrome, fetal warfarin syndrome, or mothers that in fact may be on things such as cocaine, which have impacts on the fetus. Anytime we talk about secondary growth disorders, we're talking about things that we require for growth. So we So we talk about our malnutrition, our chronic diseases, and then our endocrine disorders such as hypothyroidism, rickets, um, resulting from either vitamin D deficiency or renal rickets. Cushing's or hypercortisolism impacts on your bone growth. It may give you initially a growth spurt, but then chronic hypercortisolism will give you growth failure. And then you look at insulin growth factor deficiencies. So that's your growth hormone deficiency, which may come from either problems at your hypothalamic level, so growth hormone releasing hormone, or pituitary growth hormone deficiency. And then in this, we put in your constitutional growth delay. All right? Okay. So at that point, we will close this lecture on growth. Any questions that you all may have? But the important thing, guys, is your growth charts and understanding how to assess your child, making accurate growth measurements, using your charts appropriately, and recognize whether your child is growing or not, and then picking up where, in fact, the problem may be in terms of failing to grow.
Doc,
Uh-huh.
is height age not like the fact that the height age is not equivalent to their actual age is normal?
No, it shows you if, depending on what, if your height age is greater than your chronological age, it's saying to you that something is pushing your bones to grow faster than normal. So we know in patients with early puberty, your sex hormones make you grow faster than normal. It could be Cushing's, so extra cortisol making you grow faster than normal. On the other hand, if your height age is less than your chronological age, it says to you that something is impacting or delaying your growth. And the question is, could this be a hormonal deficiency like hypothyroidism, or could it be a chronic disease, or could it be malnutrition? Okay?
So for children with a genetically short stature, the height age should equal their chronological age?
Yes, it does, right? Well, so in the genetic group, their height age is equivalent to their chronological age, which is equivalent to their bone age.
Okay.
All right, so what we'll do is we'll let you guys take a 30-second bathroom break as I set up for our next talk. Okay, here we go again. And this, we're going to talk about disorders of sexual maturation. And I guess this really is about what makes us male and what makes us female. And we're going to look at this through the neonatal period, where we're going to deal with ambiguous genitalia, childhood, where we deal with precocious puberty, and adolescence, where we deal with delayed puberty. Right. So let me ask a few questions. What makes you male and what makes you female? Anybody can feel free to chirp in.
That I guess it could be based off a phenotype or genotype. So phenotype being the appearance and visible sexual characteristics, and then genotype being whether you're XX or XY or whatever variant there may be.
Okay. Sure. So essentially, which one do you think, Akil, is more relevant in the population?
Phenotype.
Right. Right. So when you came into med school and you met everybody, we all make assumptions based on phenotype, but not many of us know your chromosomal status. And so you're perfectly right. So we're looking at our phenotype, and then you have your genotype, which are really your chromosomes, and then you have your gonadotype. And in most of us, all of those follow together. So your gonadotype is congruent or the same as your gonadotype, and your gonadotype results in a phenotype which is congruent with everybody else. Okay. So where we have challenges is where those are not congruent. So our gonadotype is maybe different from what we expect our genotype to be, and then our phenotype is maybe different. So we're going to talk a little bit about that. But I also wanted to just comment that this has nothing to do with your gender identity. All right. So when we're talking about LGBTQ, etc., gender is who you see yourself to be, which may be totally independent of your gonadotype, your phenotype, or your genotype. Okay. And so your gender identity, you usually develop somewhere between the age of 2 and 4 years, where you in fact see yourself as a boy or a girl, or you don't know what you see yourself as. And so when in fact your gender identity is not the same as your phenotype, gonadotype, genotype, then we will look at that as a gender dysphoria. And so that's so where you're just saying your gender is different from what your physical and other characteristics are. But that's not for us to talk about today. We're going to talk a little bit about the other stuff. Let me go back to the slide. Okay, so this you know, essentially On your Y chromosome, you code for your Y antigen from your Y determining region, and your Y antigen interfaces with your primitive gonads, which lie on the posterior abdominal wall. And the primitive gonads, in the presence of the Y antigen, actually will, in presence of the Y antigen, will result in differentiation of that primitive gonad into a testes. All right? And it's important to recognize that most hormonal structures are not autonomous. They usually require stimulating factors to get them to work. So once your testes have been differentiated, they are stimulated by the placental HCG, human chorionic gonadotrophin, and then they produce testosterone, Müllering inhibiting factor, and androgen binding globulin without the G. So that's where what your testes starts to produce Müllering inhibiting factor, also called Müllering inhibiting hormone. And also what then happens is your testosterone is reduced by a 5-alpha reductase in the tissue, and this enzyme is in the tissue to produce dihydrotestosterone. And dihydrotestosterone is that hormone which helps to create acne, which we don't like, but it also is an important facilitator in the development of the male external genitalia. And as an additional note, it's important to recognize growth hormone, GH, needs to be present to facilitate penile growth. So in either the presence of, in the absence of growth hormone or in the absence of testosterone, you're going to have a micro penis. So both of those are important for the development of the penis. Okay, so as we look in terms of our external genitalia, we all start off in an indifferent phase where we have a genital tubercle or urogenital slit. On either side of that, you have the urethral folds, and then you have the labioscrotal folds. Under the influence of testosterone and dihydrotestosterone, your urethral folds, okay, come together, and I like to use the term, they're zipped up from a posterior to anterior position. And that zipping up is forming your median raphe, okay, along the dorsal aspects, ventral aspects of the penis. The genital tubercle becomes a glans penis, and you can see that if you don't zip this up properly, you're going to end up with a form of hypospadias, okay? And so that, in fact, the zipping up is facilitated not just by testosterone, but by dihydrotestosterone. So dihydrotestosterone is very important in this aspect of closure of the urogenital slit. We have the labioscrotal folds now on either side, which await the descent of the testes. And the testes will descend from the posterior abdominal wall through the inguinal scrotal canal and then rest within the scrotum. So here we have a normal, oops, let me go back. Right, so here we have a normal scrotum, median raphe, glans penis, and the urethral opening at the tip of the penis as normal. On the other hand, in the absence of testosterone and dihydrotestosterone, the genital tubercle becomes the head of the clitoris, okay? And remember, the clitoris, even though we see the clitoris externally as the gland, it extends down behind on either side, all right? So the clitoris is a sort of Y-shaped structure. So you have the glands becoming the clitoris that we see. We have urethral folds on either side becoming the labia minora, and the labia scrotal swellings become the labia majora. When one looks at the vestibule, one will then see initially there's a single opening, a single cloacal opening, but then the urethra migrates from the anterior surface to produce its own opening. So you have the urethral opening, and then the cloacal opening remnants become the vaginal orifice. Okay, so all of this now happens de facto in the absence of testosterone and dihydrotestosterone. When we go on the inside now, we have both sets of genitalia. We have our Mullerian system and we have our Wolffian system. In the presence of testes, we have the production of Mullerian inhibiting factor, which is a locally acting hormone. So it only acts on the side that it is secreted. So when we have two testes, we end up having regression of the Mullerian system. And the Wolffian system continues to develop under the influence of testosterone and androgen binding globulin. On the other hand, if we have one testis and one ovary, on the side where we have the ovary, we're not going to have any Mullerian inhibiting factor produced, so we're going to have persistence of a fallopian tube and hemiuterus on that side. Okay? In the absence of testes, then the Wolffian system regresses and you're left with your Mullerian system. And remember that the upper two-thirds of the vagina comes from your internal genitalia, and it joins with ectoderm from outside to create your vaginal vault. Where the two meet is where you get the hymen. You have different hymens. You have the semilunar, the perforate, and the imperforate. Obviously, the semilunar hymen is the most common, and the imperforate most uncommon. All right. Any questions at that point? So as we move into ambiguous genitalia, you're in the delivery room and everybody's waiting to hear from you, whether it's Mobay, New York, London, Tokyo. What kind of baby do we have? Is it a boy or is it a girl? And what kind of baby is that? You guys don't know what that is? Or nobody wants to comment?
It's a boy, sir,
Why is it a boy?
because it has a testes and a penis.
So how you know it has a testes? Well, you can't define something with our own words, right? So you can't use the word penis to define a penis. But just to comment, and I agree with you, it's a boy. What we can see here what looks like a testicular swelling and another testicular swelling there. We have a phallic structure, which is of significant length and circumference, and we have hyperpigmentation with rugae, which indicates that we've been exposed to testosterone. And here you can see a median raphe kind of coming up through the scrotum. And you can't see it obviously on the penile side. But one of the things is we can also know that we don't have any swellings in the inguinal canal. Swellings in the inguinal canal can either be testes that are not fully descended, or they can be ovaries. Sometimes ovaries can in fact prolapse into the inguinal canal. So one really has to, when we see gonads in the inguinal canal, really make sure those are testes that are undescended rather than ovaries that have prolapsed. Okay, so what do we have here now? Nobody wants to take a guess? Or is everybody sleeping? So when we get to face-to-face, I just call you guys out. All right, so Chanel thinks it's ambiguous. Both of them?
Yes, both of them.
Okay. All right, so it's ambiguous, but let's talk about. So essentially what we have here on the right, I think it's right, you're right too. The question is this a small penis with undescended testes? Or is this a female who has an enlarged clitoris? On the other hand, we see on this side the same question. We're not seeing any gonads up here, not seeing any gonads down here. We've got a significant phallic structure, which could very well be a penis, but also could it be a clitoris, which is enlarged. And once again, we have our labial scrotal folds, which don't have anything in them. So we're not sure whether we're dealing with an undervirilized male or a virilized female. All right. The most important thing, this is a medical urgency. It's not necessarily an emergency. But we do need to define this child rather quickly so our parents can bond and name the child and be able to go home and tell the family they have a boy or a girl. So it's not something that we say, okay, we'll work you out in clinic in 3 months' time. Parents want to know what sex they have, and it's also important that we define it for them so that they don't think they have a freak. And what we really say to them is that the maturation and development of your child's external genitalia is incomplete and doesn't allow us to define it at the delivery. And so we need to do some investigations to define your child's status. So virilization and masculinization are the same kind of word. So if we look at boys may be under-virilized. And this may be because they have a problem with their testes. So the structure, the factory may have a problem. So when we look at the factor that's producing testosterone, we can have a condition where we have congenital anorexia, where in fact there are no testes because of maybe a vascular event or damage to the testes, so the testes don't develop. That event may not have completely wiped out the testes, or we may have testes that are hyperplastic, so they're smaller and don't function as well, and so we have an inability to produce enough testosterone. On the other hand, the structure may look normal, but we have the cells inside, which are the Leydig cells that produce testosterone. Maybe they may be hyperplastic, even though the testes themselves are not hyperplastic. On the other hand, we may have a structurally normal testes, but we have enzyme deficiencies, and we call those testosterone biosynthetic inborn errors. And so the various enzymes, which you don't need to know at this stage of life in your medical life, but just to know that within the pathway to producing testosterone, we may have errors, we may have enzymes that are deficient, such as 17-alpha hydroxylase, 17-20 lyase, and 3-beta hydroxysteroid deficiency states, okay? We talked about the 5-alpha reductase, which is important to convert testosterone to dihydrotestosterone. And if that hormone is deficient, we're going to have problems in developing the external genitalia. So we may then end up with ambiguous genitalia. On the other hand, as we move on, we recognize that we may be producing normal hormone, but the receptors are not working. So we could have issues with androgen receptors in terms of the number of receptors available or the structure of the receptors. So if we in fact don't have enough receptors and we're only getting some response, then we could have a partial androgen insensitivity syndrome where we can't completely develop the external genitalia in a male. However, if we have no receptors, okay, then we're going to end up with a phenotypic female. So we're going to have a female who has XY chromosomes, testes that are usually intra-abdominal, no Mullerian system, but because there are no receptors, the external genitalia are female, and she's going to have a vaginal ball created from her external genitalia. Because all males have a little vaginal ball, but under the influence of DHT, that becomes atretic and closes up. So individuals who have total androgen insensitivity are phenotypic females with testes and chromosomal XY. Now, on the other hand, we may have problems where we have chromosomal anomalies. And those chromosomal anomalies, we may have XX males, where there's been a translocation of the Y-determining region onto an X chromosome. We have an XX male. When we talk about true hermaphrodite, we're not really using that term anymore, but that's really saying that we have both male and female gonadal tissue in the same individual, and that's a disorder. We're now using the term disorder of sexual development, or DSD. So you can have both ovaries on one side, testes on the other side, or you may have an ovotestes on one side and a testes on the other. or an ovotestes and an ovary, or two ovotestes. So you have all sorts of combinations of gonadal issues. And then we can have what we call XY gonadal dysgenesis, in that during the development and differentiation of the testes, they become dysgenetic. And when the dysgenesis happens, you may end up with ambiguous genitalia. On the other hand, in a virilized or masculinized female, you may have that same group of disorders we just talked about, or we may actually have that fetus exposed to maternal androgens. So sometimes mothers may have ovarian tumors that produce androgens, or the corpus luteum, which should go away once you're pregnant, but continues to get stimulated by HCG, produces excess progesterone, and that causes virilization of the female. Or the mother may have congenital adrenal hyperplasia, producing excess androgens. On the other hand, in the people used to use danazol, which is an androgen to treat endometriosis. So sometimes a woman would get pregnant while on danazol, and that danazol, that hormone, would result in virilization of the fetus. So the mother may be providing androgens to the fetus to cause changes in the external genitalia. On the other hand, the fetus may do it themselves. The fetus may have congenital adrenal hyperplasia. Yes, Anya, you had a question?
Yes, doc. So for example, like persons who are transgender, like transgender males who are genetically female, and those persons who retain their female reproductive parts and decide to get pregnant, are their children at increased risk? For example, the females, are they at increased risk of becoming masculinized because of the fact that they would have been taking those hormones prior to pregnancy?
The quick answer is only if they continue to take them during pregnancy. But remember, for them to maintain their status, they have to continue taking the hormone. And so if they were to get pregnant, or they wanted to get pregnant, they would have to come off those hormones during the time of their pregnancy. Follow?
Okay, thank you.
Yeah, because they can only maintain, and that happens to all of us. We can only maintain our various sexualities if we if we continue to produce either testosterone or estrogen. So obviously, once we have completed our development, the presence of sex hormones is not going to change our external features, and that's why those individuals would need to do surgery to change their external features. But their hormonal status, they need to be on, if you're going from male to female, they need to be on continuous estrogen. If they're going from female to male, they need to continue to be on testosterone. All right? All right, so this graph you guys should know from your chem path very nicely. And it really looks at the adrenal gland and its pathways, where it takes cholesterol and passes it through a number of enzymatic steps. So you produce mineralocorticoids, which is aldosterone, glucocorticoids, which is cortisol, and then your sex steroids. All right. Now your adrenal androgens are DHEA and androstenedione. Okay, and excess amounts of this are converted to testosterone. And these are the enzymes we kind of talked about, your 17-alpha hydroxylase. The important one is your 21 hydroxylase, which converts progesterone to 11-deoxycorticosterone and progesterone to 17-hydroxyprogesterone to 11-deoxycortisol. So this pathway is driven by ACTH and cortisol. But remember, cortisol does not control aldosterone. Aldosterone is controlled through your renin-angiotensin system, through your juxtaglomerular apparatus. So mineralocorticoid control has nothing to do with glucocorticoid, right? However, we have isoenzymes in both pathways. So deficiencies of these isoenzymes will result in the situation where we have a cortisol deficiency as well as an aldosterone deficiency. So you are Addisonian because you're a cortisol deficiency, and you don't have aldosterone, so that you are salt wasting. And because of that, your progesterone gets shunted into your androgenic pathway. And so you increase the amount of androstenedione, testosterone, and DHEA because your glucocorticoids keep trying to increase your ACTH. Now, increased ACTH is going to have a melanocorticotrophic effect as well, so it's going to make you hyperpigmented. So these children who have cortisol deficiency, aldosterone deficiency, apart from being Addisonian and salt wasting, they're also going to be hyperpigmented with evidence of excess androgens. So when we look at congenital adrenal hyperplasia, it's really the commonest cause of ambiguous genitalia. It's inherited as a recessive gene on chromosome 6, and there are really three forms. You have the classic and the non-classic, and the classic form can be divided into simple virilizing, where you don't have problems with aldosterone, so that enzyme is present, or classic salt wasting, where you have both virilizing and salt wasting. The non-classic form usually presents in females in adolescence and young adulthood, and they in fact are part of the this is part of the differential diagnosis in polycystic ovarian syndrome. So these ladies may have irregular menses, mild hirsutism because of the block and the increased androgens, and so they fall into that category of polycystic ovaries. And so individuals with a diagnosis of polycystic ovaries, they should be considered also to have non-classic congenital adrenal hyperplasia. Now, obviously, boys with CAH are not going to present with ambiguous genitalia. They're going to present with precocious puberty. because you're going to have excess androgens at an early age, while girls with CAH are going to present with ambiguous genitalia. Now, obviously, the treatment, what you make the diagnosis is simple. You replace the cortisol with using hydrocortisone at that dosage. And so hydrocortisone then feeds back onto the pituitary and decreases your ACTH, so your hyperpigmentation settles down. For those salt wasters, we use fludrocortisone, which is a mineral corticoid, which supplements and replaces aldosterone deficiency. And then we do surgical revision. Depending on the degree of clitoromegaly, clitoroplasty may be done somewhere between 18 months and 2 years. And because of the impact of the androgens on the vagina, you may have some vaginal stenosis, and so vaginoplasty may need to be done during your teenage years. Parental counseling to let parents know that they certainly have a girl whose fertility will be fine and will need to undergo revision. There's some girls in which the clitoral enlargement is not significant, and as they get older with control, the labia majora cover the clitoris, so they don't need to undergo resection. It's important when there's that the procedure for clitoroplasty is not amputation of the clitoris, but preservation of the dorsal nerve of the clitoris, so that you maintain clitoral sensation. So that's your CAH. Our next situation is where we're going to go into precocious puberty, where normal puberty results as a consequence of the episodic resurgence of gonadotropin-releasing hormone to stimulate the pituitary gland and release LH and FSH. And why I put this as a resurgence is because at birth, there is a surge of LH and FSH, and newborn baby males will have testosterone levels in the first couple of weeks of life, which are adult levels. By 4 to 6 weeks, all of that has settled down, and the axis goes to sleep until puberty starts again. So we call that in the newborn a little mini puberty. But in normal puberty, you get gonadal stimulation of either the ovaries and testes, and that results in the release of testosterone or estrogen. Now, when we have precocious puberty, we get either a premature stimulation of the axis, the hypothalamic pituitary gonadal axis, and when that happens, we call that true or central precocious puberty. On the other hand, we may have sex hormones coming either from the ovaries or the adrenal glands or the testes, which are independent of the axis being involved. And that's called pseudo or peripheral precocious puberty. And we define it as the onset of secondary sexual characteristics prior to 8 years in girls and 10 years in boys. When you read some of the American texts, you'll hear them talk about African Americans, and they use 6 years in African Americans. But we don't have any African Americans in the Caribbean, so we use 8 years. All right? We have just regular Afro-Caribbean people. So true precocious puberty, as I said, results from stimulation of the axis, while in pseudo there is no involvement of the axis. Now, we then go to idiopathic through precocious puberty. And idiopathic through precocious puberty really says we don't have a cause for what's causing the precocious puberty. 95% of girls with precocious puberty are idiopathic, while 60% of boys are idiopathic. So we are more likely to find a cause in boys than we are in girls. Okay? Now, when we look at our brain, the early brain tends to have an excess of inhibitory neurotransmitters rather than excitatory neurotransmitters. And as you develop and get older, you get more and more excitatory neurotransmitters in terms of the balance between inhibitory and excitatory. The increasing excitatory neurotransmitters will then at some point lead to an ability to receive to recognize negative feedback and start the stimulation of your pubertal process. However, anything that impacts on the brain early may result in a change in the balance of your inhibitory and excitatory neurotransmitters and start the pubertal process early. So we see patients with cerebral palsy, hydrocephalus, head trauma, irradiation, patients with chronic inflammatory disorders and tumors such as pinealomas, gliomas, craniopharyngiomas. These are all conditions which are going to increase your risk for precocious puberty and give us a cause for the child having early onset of puberty. On the other hand, in pseudo-precocious puberty, we see things like ovarian tumors. We have granulosa cell tumors, juvenile granulosa cell tumors, which produce estrogen. We have significant ovarian cysts that may do that. And there's a syndrome, McCune-Albright syndrome, where you have precocious puberty associated with large ovaries and caphylate lesions on the skin and fibrous dysostosis of the bone. That's a condition in which girls get precocious puberty. In terms of neurofibromatosis, neurofibromatosis can give you two types of precocious puberty. You may get it because of neurofibroma in the brain, resulting in early onset of puberty. Or you may get neurofibromas in the adrenal glands, which produce hormones that are going to give you precocious puberty. We talked about CAH in boys, congenital adrenal hyperplasia in boys, and there's a rare condition in boys called testotoxicosis, where the testes actually become autonomous and produce testosterone. It's a rare, unusual condition. It's usually familiar, but basically, once again, this is pseudo because there's no involvement of the hypothalamic pituitary axis. Now, once again, we're going to go look at some normal variations of puberty. And just to define, PILA is breast development in girls, while gynecomastia is breast development in boys. Premature thelat is a normal variation where you get isolated breast development, which is non-progressive. usually occurring between 9 and 18 months of age, and these little girls will suddenly develop some breasts. They come up and they stay, but they don't progress. And this is different from the breast development that may occur in the newborn, where transference of maternal estrogen may cause some breast development in both boys and girls in the newborn period. There's a myth, not only in Jamaica, but Haiti as well, and in some of the other Caribbean islands, that we need to squeeze that breast to prevent body odor later on. We certainly try and tell parents to leave the breast alone in the newborn. They will go away, they'll settle down, and you can risk developing abscesses in the baby, that sort of thing. All right? So premature TLAC is different from that neonatal gynecomastia TLAC that we get earlier on. In premature TLAC, if we do assessments, we find that the FSH may be mildly elevated compared to the luteinizing hormone, and estrogen levels are normal for age. Unlike in true puberty, the LH is usually increased over FSH. Investigations for premature TLAC, mostly we'll do a pelvic ultrasound to make sure there are no significant ovarian cysts or tumors, and then we reassure the parents. Now, adrenal is the development of your adrenal features from your adrenal androgens, DHEA and androstenedione. In adrenal, you have isolated both pubic and axillary hair development, as well as apocrine glands. So your apocrine glands are your sweat glands in your axilla and groin, and under the influence of skin flora, they give you the famous body odor, okay? So you find children who run up and down and play and get sweaty and don't have a body odor until they start to have adrenal stimulation of those apocrine glands. Now, premature adrenal may be either due to a mild increase in your serum DHEAS, your dehydroepiandrostenedione sulfate from your adrenal gland, or you may have normal levels of DHEAS, but these pilosebaceous hair units are sensitive to those normal levels, and you end up with premature adrenal. Kids with premature adrenal tend to go into puberty at the earlier time of normality, okay? Because they tend to have a slight increase in their growth rate, and so they may go into puberty a little bit earlier than the average, but still within the normal range. So they're not going into precocious puberty generally. Now, menarche is the first menstrual period, so that's called menarche. And premature menarche is a rare situation where girls may have a menstrual bleed at an early age without showing any other features of estrogen stimulation. So they haven't started their normal puberty with breast development, etc., but they have a bleed. And this may be related to either increased sensitivity to normal circulating estrogen in the uterus, or they may have had a ovarian cyst that produced estrogen and they've got a withdrawal surge. Now, this is a diagnosis that you rarely make. Children with PV bleeding, you need to ensure that there's no foreign body, no sex abuse, And foreign bodies may be anything, including worms. Sometimes worms may travel into the vagina from the anus and cause a vaginitis. Little girls may put things into the vagina, such as tissue. There are all kinds of things that can come out of the vagina. And then you have to make sure that there's no child abuse as well. So it's important that we recognize that this is an unusual and rare situation, and we look for all the other causes. An important cause to mention is urethral prolapse, where especially little girls with constipation and chronic straining may actually flip out the urethra. So you have a tube, but the lining gets flipped out. And when you look at the vestibule, you see a donut shape at the urethra. And every time they wipe, they traumatize the exposed urethra and they bleed. But do remember about urethral prolapse as a cause of bleeding. Right. So essentially what we'll do to investigate these kids, certainly we want to look at the growth velocity, because if you have sex hormones being secreted, they're going to increase your growth velocity above what is normal for the age. You look at the bone age, whether to see that's advanced. And for boys, we can use an oxidometer to measure the testicular volume. And I let you Google oxidometer and you'll see. And the prepubertal testicular volumes are 1 to 3 ml or mils. Once you're above 3 mLs, you're going to 4 or 5, you have started puberty. All right? The adult volumes are between 15 and 25 mil volumes. For girls, we can't easily measure the ovarian volume, so we will do pelvic ultrasounds, and the ultrasounds can actually tell us the volumes of the ovary to see whether we're seeing a stimulated ovary. We can do static blood tests looking at LH, FSH, estradiol, and DHEAS or testosterone in males to see whether they're in the pubertal range. We don't do stimulations of the axis anymore like we used to. So we used to do LHRH stimulation where we test the axis to see what the LH and FSH levels were and whether we got a steep rise in LH or FSH or whether the axis was flat, indicating an unstimulated axis. If we think that we have precocious puberty related to intracranial pathology, then CNS imaging is important to rule out craniopharyngiomas, hypothalamic gliomas, etc. Okay? So we don't routinely do CNS or brain scans. However, if I have a 4 or 5-year-old started really early versus a 6-year-old, 7-year-old, then we're definitely going to make sure that there's no central lesion that's causing precocious puberty. The treatment, obviously, you treat if you found a pathology, then you treat it. Okay, so if you have CAH, you treat CAH. If it's idiopathic, we used to use Depo-Provera, which is a weak androgen, but that didn't impact on stop your growth, and had the side effects of androgens. So we don't use Depo-Provera anymore. We can use cyperteroic acetate, which is an anti-androgen, which actually blocks the axis. And this is also used for prostate cancer. And it's an oral medication. The problem with it is that it comes as a pill, and we give it 3 times a day. So compliance can be a challenge in any medication that you're giving 3 times a day. We have available Gnrh analogs, and these are injectables, and they're 1 month and 3 month injectables. Jamaica, we only have the 1 month injectable, so we have to give it every month. And so the Gnrh analogs, what they do is they competitively inhibit the pituitary. So they go and they bind to the LH receptors on the pituitary and block them. And so GnRH cannot stimulate the pituitary. So they are competitive inhibitors, and they work well, and they just turn the axis off. So that's our therapy for precocious puberty. A lot of times we have girls in grade 3 or grade 4 who may be about to have periods, and the question is, why would you stop the period? We're really doing it from the psychosocial aspect, because in the psychosocial aspect, you have a little girl in grade 3 or grade 4 who's having a period every month. Her peers are not. So that's one of the challenges. The other challenges, there's hormonal changes, impact on mood, and although self-esteem. And so she's dealing with in grade 3, 4, 5 issues which teenagers have problems in second and third form. And then you also have all the feelings of sexuality, libidos comes up, which actually is happening in grade 3 and grade 4. And these are feelings, once again, that are inappropriate for a grade 3 or grade 4 child, which also is going to impact on how they feel, their emotions, and how they're able to concentrate in the school setting, etc. So those are some of the reasons why. So I say to parents, it's not just a matter of stopping a bleed, which is big enough, but there are lots of other things that the hormonal changes result in from a psychosocial aspect. And our final comment is on puberty, delayed puberty. And one of the things, we see lots of patients coming in and they go to doctors and they're not, puberty is not progressing. And the doctor says, oh, we just watch it, we just watch it. But that's why we have a definition. So for delayed puberty, it's failure to achieve Tanner stage 2 by 12 years in a girl and 14 years in a boy. And I do want you to go and research your Tanner stage or sexual maturity ratings, which are the clinical stages of puberty in boys and girls. So when we're looking at delayed puberty, we're talking about it as different from delayed menarche. A delayed menarche or delayed period is a girl who has gone through her normal menses or her normal puberty, but has not started her menses. Delayed puberty is where we have not started the normal process of puberty, or we've started the normal process and something has arrested that process, okay? So our causes are, as we talked about in an earlier lecture, constitutional delay of growth and adolescence. So those kids with constitutional short stature are going to go into puberty later. Then we have hypergonadotrophic hypogonadism. And in this situation, there's a problem at the level of the gonads. So you're not getting any feedback to the axis. So you have elevated LH and FSH and decreased sex hormones, either estrogen or testosterone. So we see this situation in patients with Turner syndrome, who may have streaked ovaries or hypoplastic ovaries, or boys with Klinefelter syndrome. All right, so there's damage to the, once we're seeing this, there's damage to the gonads, and so you're not getting any feedback. So your pituitary is trying hard to kick your gonads into action. Boys who may have had bilateral torsion of the testes, or girls who may have bilateral ovarian torsion, these things give you hypergonadotrophic hypogonadism. On the other hand, you have hypogonadotrophic hypogonadism. So you're not getting any signals from either it's the hypothalamus or the pituitary to stimulate the gonads to produce LH and FS, to produce estrogen and testosterone. And in this situation, you need to worry about, is there a brain tumor either at the level of the pituitary or in the hypothalamus that's causing inability for secretion of LH or FSH? Or could it be a prolactinoma, which is blocking LH and FSH secretion? So when we see this, we want to know what's going on at the level of the brain. We recognize that there are syndromes, such as Kallmann syndrome, where we have hypogonadotrophic hypogonadism associated with loss of smell, and that's usually in boys. Okay, and this has been around for COVID. So we have to recognize, if we are not going into puberty, or puberty has started but stopped, what is the reason? Delayed menses may be because of a structural problem at the level of the uterus, or it may be an imperforate hymen, or we may have an abnormal development of the uterus, such as in Mullerian dysgenesis or agenesis. So we have to separate delayed menses from delayed puberty. And the treatment for either hypergonadotrophic or hypo is replacement. So we've got to replace either estrogen or testosterone, whether we're talking about male or female, and the replacement is for life. If you have gonads and the problem is at the brain level, we can eventually stimulate those gonads so that, in fact, you could get maturation of your ovaries or sperm, so that we could, in fact, have some form of in vitro fertilization and have a pregnancy or have a child. Yeah. Okay, so that's it in a nutshell. It was a big nutshell. Any questions? Are you guys still there?
Yes, we are.
Okay.
Sir, you mentioned something about COVID.
All I was saying was that Kallmann syndrome is a condition where you have hypogonadotrophic hypogonadism in boys, and it's associated with anosmia, so the loss of the sense of smell. And I was just saying that, whereas that is a symptom of COVID now, that has nothing to do with COVID. That syndrome results in problems with the olfactory nerve. Right?
Okay, thank you.
Okay, guys, thank you. So we'll sign off if there are no further questions.
Thanks, Doc.
Good morning, everyone.
Good morning, Prof.
Okay, great. I just wanted to make sure that you're hearing me. All right. I'm sorry about that. I actually only just remembered there was some discussion between myself and Prof. Theme about switching. So I am going to present to you basically a lecture which involves children with HIV as such. I may skip over some slides in the interest of time, but let us see how it goes. So for this presentation, my hope is that by the end of it, you'll be able to describe some basic pediatric HIV pathogenesis, recognize some of the important presenting features of HIV, and to also be able to describe strategies for management for these affected infants and children. So let's look a bit at pathogenesis as such. So there are some key differences between pediatric HIV and HIV in adults or older adolescents. One, for pediatric HIV is primarily perinatal transmission in terms of mother-to-child transmission. And the virus, when it infects a newborn, a very young child or infant, has significant effects on the immature immune system for that infant or child. And as a result, you get a marked virological response as such. And what that leads to is a significant deterioration in the infant or child's immature immune system by actually damaging the CD4 cells and the immature CD4 cells as such. As a result of which, clinical presentations in infants or children tend to be fairly early compared to adults. And for infants and children less than 18 months of age, you cannot use the routine antibody tests. You have to use some virological tests to be able to determine. So those are the key differences between the infected adults versus children. So as far as the possible routes of transmission in children, as you can see from the slide, it can either be in utero at birth or during breastfeeding. So the most common and most risk period for transmission is at birth, because the newborn during labor and delivery can be exposed to highly infectious fluids which are blood contaminated with, and of course with the virus as such. In utero, less common, and certainly with breastfeeding, definitely. If there is breastfeeding, you can get direct transmission of the virus through the lymphocytes within the breast milk itself. Other modes of infection, what we have seen here in Jamaica over the years, sexual, for the younger infants and younger children, definitely as a result of abuse and as well as exploitation, and for the older children and adolescents, of course, experimentation. Transmission is very rare in Jamaica, and it should be, because we have had the blood bank service is well equipped to handle and to manage and screen for bloods accordingly. Intravenous use, very rare in Jamaica. Generally speaking, people are afraid of needles, so we don't really see much of that at all compared to in North America as such. So herein lies another difference in terms of the way the infection occurs in infants versus children. So with adults, when you get the first acute infection, you get a sharp rise in your viral load or viral copies of the virus, marked multiplication, and it fairly quickly falls to a plateau by about after about several months and you get a sort of set point that is produced where you have your adult immune system balancing control of the viremia during that plateau phase. With infants and children, there is a marked difference. So you do get the significant rise in your HIV viral load, but that takes several months to years before it actually falls to a plateau, if it ever falls to a plateau at all. And therein lies the difference. So you, in the unnatural, in other words, in the state where there is no treatment to that infant, you get this marked, prolonged, very high viral load, which is persistent over time. And of course, you can imagine how much that affects the infant's and immune system per se. So for those, if you have early infection, generally their infants are well at birth. However, shortly after that, because of the rapid rise in your viral load, right, and the fact that it affects the immune system fairly quickly, all right, the tendency for symptoms and signs to occur early are more likely in the young infant compared to the older child, all right. Hence, you have the general pattern of progression of the disease from the asymptomatic phase all the way to the severe phase. And in young infants, that occurs fairly rapidly, which is a little different if an older child acquires HIV or an adolescent. Then it takes a longer time for you to move from the asymptomatic phase to the moderate to severe and phase per se, as such. And we tend to see three sets of patterns in terms of the natural history of HIV, whereby you have the rapid progressors. And these are the infants who acquire HIV usually in utero and shortly after birth become very symptomatic and usually have acquire like PCP or other opportunistic infections and die within a year or two of birth. Then you have the intermediate pattern of progression, and these are the infants or children who acquire infection early, yes, but they have a slower progression, so they may not manifest any symptoms until about 3 or 4 years of age, and usually, it's like recurrent infections, typical infections that you would see. Examination, you may find persistent lymphadenopathy. They may have recurrent respiratory infections, and the penny doesn't drop until, if the clinician realizes that this child is having too many infections. Let me have a look and see what the immune system is like. All right. Then, of course, you have this small percentage who progress fairly slowly, and these are the children who, for years, will show no symptoms at all of HIV, and when they reach like about 7, 8, 9, 10 years of age, even more older than that, they only and then that they start to manifest symptoms as such. So I'm saying all of this because this is a sort of pattern that we used to see, I would say, in the last 15 years or so, as such. Currently, y'all are not going to see this pattern at all because there's a different approach in the whole management of HIV. And the approach is early infant diagnosis, early treatment. So you're not going to see this sort of presentation like we saw, because at the time we didn't have the interventions at hand to be able to manage the infection appropriately. All right. So this is the old classification. I'm putting it up because you may still see it in terms of how we classify HIV using the Center for Disease Control clinical categories. And it's old because it was done in 1994, and it was created for the purpose of surveillance. So, and it's classified based on the clinical symptoms that the patient has. So N would be asymptomatic, A would be mildly symptomatic, whether you may have like lymphadenopathy or enlarged parotids or hepatosplenomegaly. Moderately symptomatic are patients who may have symptoms related, especially to the hematological system, anemia, thrombocytopenia, and the like. And of course, severely symptomatic are those who have AIDS-defining conditions. The most revised classification, it was revised in 2014, and it was revised based on, again, advances in diagnosis and management. So it's now stages 0 to 3. So 0, we have early acute infection, and these are patients who have no symptoms at all, and the diagnosis is made having had a previous negative HIV ELISA and having detectable antigens in the sample that has been being used, and especially if there's been previous exposure to HIV. In our setting in Jamaica, it's very difficult to detect patients with acute early infection, but certainly the stage 1 to 3 is similar to the older classification, where 1 is asymptomatic or mild symptomatic, 2 moderate, and 3 severely symptomatic, having AIDS-defining conditions. Then, of course, you have the classification based on immune category. And what I put up here is for children who are greater than or equal to 6 years of age. If your CD4 percentage, as a percentage of CD4 cells relative to the total lymphocytes count, is, well, this sign here should be greater than 26%. Would be none or mild suppression. Category 2, where you have 15 to 20% moderate suppression, and 3, less than 40% severe suppression, in keeping with somebody who has AIDS. This is a more detailed representation of the classification based on immune status, and it's broken down by infants less than a year of age, children between 1 to 5 years, and those, of course, greater than 6 years. So I already spoke about greater than 6 years, all right? And if you look at it, besides the percentage, you also have the absolute CD4 count congruent with that. Greater than 500 and equal to 500 cells would be category 1, 200 to 499 category 2, and less than 200 would be category 3. Now, there's a reason why there's a difference in the parameters for the 1 to 5 and the less than 1 year. And the reason is that you're in the natural development of lymphocytes, it's different in the younger child compared to the older child. So the child older, greater than 6 years or so, is the immune system is relatively well developed, and it is similar to what you would see in an adolescent or an adult. With the younger child, you have a more brisk proliferation of lymphocytes, and hence the reason why the parameters are different. Okay, just for you to realize that. So let's look at a few cases and clinical cases, and then we can discuss each of the cases accordingly. So in case one, it's a 3-year-old boy who's known to be HIV positive, and he had a 2-day onset of fever, cough, and shortness of breath. He was on examination having acute respiratory distress, as evidenced by flaring of his alienacy. He had intercostal and subcostal recession. He had pale mucous membranes. There was bilateral bronchospasm and coarse creps on auscultation, and his oxygen saturation was 90% in air. So what would be your diagnosis? Well, I mean, I guess the most common thing that somebody would think of is whether this child is having a pneumonia, right? Or maybe wheezing. So yeah. So does this child have a lower tract infection, a pneumonia, reactive airway disease? I mean, he is, how old is he? I said 3-year-old, right? As such. Well, there are different things to consider. So this is X-ray of this child, and if you notice that he has sort of infiltrates in the lower zone, especially on the right. You can't really see it very clearly, but they're supposed to be reticular nodular. He has hyperinflation. You can see the right diaphragm is even lower than the left diaphragm. And for this child, the differential diagnosis would be something called LIP. Can be PCP. Does he have chronic lung disease or other opportunistic infection? So let's talk about LIP. So lymphocytic interstitial pneumonitis. It's a common disorder in children who have well-established HIV, and the pathologically what you see is diffuse infiltration of CD8 cells and plasma cells within the lungs. The patient presents usually with cough, dyspnea, tachypnea, and wheezing as such. And you will notice the other thing that the patient may have is clubbing, as you can see here in this picture. And that clubbing is because there's chronic hypoxia or chronic hypoxemia, which is occurring in the context of the patient. In the advanced stage, as I said, there's clubbing because there is persistent oxygen desaturation. Patients usually present with generalized lymphadenopathy. They may have hepatosplenomegaly, enlargement of the parotids, and clear lymphocytosis when you check the CBC per se. The diagnosis is primarily clinical. There is no test to say whether or not it's so. Clinical, also the radiological pattern, and the patients usually have these recurrent episodes of respiratory distress, commonly triggered by an infection. So they may either progress to chronic lung disease and respiratory failure, or they resolve. Currently, because we treat the patients with antiretroviral therapy, we don't really see this condition much anymore at all, and the condition resolves with the use of antiretroviral therapy. In the acute stage, the patients are managed appropriately with bronchodilators and steroids in some regards. Okay. Other possible condition that this child could have is PCP. All right. And it's a common age-defining condition in young children. As a matter of fact, the risk of morbidity and mortality for PCP is greatest in the first 12 months of age. All right. So the peak time that we actually see PCP in young infants is, in the sort of mid 6, 2 to 6 months of age per se. And the cause of the infection is a fungus, Pneumocystis jirovecii, as such. We used to think was some other organism, but it's now known to be a fungus, jirovecii. And what happens is that this fungus, it causes erosion of the alveoli, this degeneration and inflammation, which impairs significantly impairs lung function. The typical presentation is these are the children who progress fairly rapidly to respiratory distress. They're tachypnic, they're mildly febrile usually, they're coughing, they're dyspneic, and the hallmark of the respiratory distress is hypoxia and hypoxemia. You may see, of course, like in this X-ray, hyperinflation, evidence of hyperinflation, bilateral diffuse pulmonary infiltrates, sometimes even a ground glass appearance or reticular nodular appearance. The diagnosis is, in our setting, is difficult to make because we may not necessarily have the required techniques to do so, which is the best techniques would be molecular diagnostic techniques after on aspirates induced from the lower airway, direct staining as such. In our setting, we often treat presumptively without making a definitive diagnosis, and the treatment is and continues to be IV Bactrim, trimethoprim sulfamethoxazole, given for 3 weeks, and then there is chemoprophylaxis subsequently. Patient, of course, needs to be supported with oxygen and oftentimes needs steroids also. The other presentation of this patient could have been that of just a typical bacterial infection, respiratory tract infection. So remember that because your immune function is impaired, and there's if ineffective immunoglobulins, then children with HIV are also going to be susceptible to the typical bacterial infections that we see: strep pneumonia, Haemophilus influenza type B, and even gram-negatives in those who have chronic lung disease. And the approach is to give more broad spectrum antibiotics as such. One of the issues with patients with HIV who end up with having recurrent bacterial infections or opportunistic infections or LIP, it progresses and can progress to chronic lung disease. And with chronic lung disease, you have actual destruction of the lung architecture, and hence these patients tend to have an increased susceptibility to recurrent infections with coughing, wheezing, respiratory distress, hypoxemia, and you have further deterioration in the lung function. Okay, let's look at case 2. So case 2 is a 10-year-old positive, HIV positive male, 4 adherence to antiretrovirals, presents with left-sided tonic-clonic seizures against a background of 3 weeks previously of having unusual behavior, headaches, he's clumsy, but there's no history of head trauma. So what is your differential diagnosis? Well, it's very clear there, whether does he have a central nervous system opportunistic infection, does he have a stroke, does he have a lymphoma, what it is, okay, as such. Well, one of the opportunistic infections that can commonly affect your central nervous system is toxoplasmosis, and can present as an encephalitis. And for patients with HIV, they would have had acquired infection previously. So one of the things that we always do in our workup is to check and see whether there is any antibodies to toxoplasma. And how they present to the encephalitis is where you have a reactivation of a previously asymptomatic infection. All right. The encephalitis is associated with patients who have severe immunosuppression. All right. And the characteristic CT changes is what you can see here. We get enhanced ring-like lesions. Okay. This is so classical when you see this on a CT. It's almost pathognomonic of toxoplasmosis. All right. The other eyes that can cause CNS problems with patients with HIV, however, is like cryptococcal meningitis. You can get the typical bacterial infections causing meningitis also. And then there's a condition called progressive multifocal leukoencephalopathy, which can also occur as such, affecting the CNS. You can also get primary CNS lymphomas, and these usually present commonly with focal neurological deficits. So something is oftentimes a diagnosis of exclusion, right? So you will get, mental status changes, headaches, seizures, but with the CT, it is not enhanced. It's, yes, you can get a mass, and you can get a circular mass, but it's not enhanced compared to the toxoplasma. With the toxoplasma, it's enhanced because there's a band of inflammation occurring, all right, as such. And these are very difficult to manage, difficult to treat. Again, we see less of this now because patients are being treated effectively with antiretroviral therapy. The other possibility also is strokes, and they can occur because, HIV itself can cause coagulopathies and vasculitides, and can also present with a hypocoagulable state. All of these can increase the likelihood of strokes in patients, but again, they're less common than we see. All right, so let's look at a potpourri of other presentations. Some of them more common or less common than expected. Well, candidiasis. Again, the occurrence is in patients who more have severe immune suppression. When it's really bad, the patients may have hoarseness and difficulty swallowing, and you must consider whether there is extension to the esophagus, and the treatment is most effectively using fluconazole, which is a systemic antifungal agent. Yes, herpes simplex again presents this. Children can commonly get herpetic gingival stomatitis, but with HIV and patients who have moderate to severe presentation, it's a fairly severe, very painful, very extensive ulceration of the lips, tongues, oral mucosa. And the problem with this, because it's so painful, the children do not want to drink or eat, and they can get secondary dehydration as a result of this. It tends to be recurrent in patients who have HIV, and the treatment is difficult, but if you start acyclovir at the very early onset of the presentation, it can reduce the severity of the condition itself. You can also use acyclovir or vanciclovir as prophylaxis to reduce the occurrences of it going later forwards. Then you have varicella zoster. So if you notice here, this is a patient, actually a patient I saw several years ago, who presented with these vesicles, pustules. If you notice, it's in the dermatome, in line with the dermatome, right, as you can see here. And it's a manifestation of patients who have moderate to severe HIV, and it can be recurrent. I mean, about several months ago, I had a patient who came to me, and she's had 3 recurrences of zoster in the previous 2 years, but she had not been on antiretroviral therapy at all, as such. And with zoster, it tends to be very itchy but painful, and as I said, the distribution is along a dermatome. You can get extension of zoster from not just the skin but also to the lungs and systemic effects in terms of developing pneumonia, hepatitis, and even CNS involvement. We can use acyclovir to treat these patients. Then, of course, you have bacterial skin infections. And very similar to patients who don't, non-HIV infected children, the common typical things that we see, cellulitis, folliculitis, abscesses as such, strep pneumoniae, staph aureus are the typical agents involved. And the other skin problems that you may see would be actually conditions which actually associated with a number of the treatments, antiretroviral drugs, or even bacterium. So they can present with erythema multiforme, even Stevens-Johnson syndrome. Bactrim, nevirapine are the two drugs that are implicated often in these presentations. Remember that otitis media, acute otitis media, is a common childhood condition, but there's increased frequency and severity in patients who have HIV infection. The ET tube dysfunction is more common. You can get ET2 obstruction because of more the lymphoid hyperplasia occurring in the nasopharyngeal area. As such, typical 8 organisms are implicated: strep pneumoniae, Haemophilus influenzae, and the preferred treatment, of course, is using parenteral antibiotics, ceftriaxone per se. Okay, sinusitis, again, can be severe or more persistent. And again, the problem in HIV is increased susceptibility because of the organisms involved: strep pneumonia, Haemophilus influenza, Varicella catarrhalis. So you have to have a low threshold of diagnosing it and investigating it and treating appropriately. Then in the GI tract, one of the problems in the GI tract with it is that in the pathogenesis of HIV, it initially infects the gut. It infects the gut mucosal cells. You get destruction and almost elimination of most of the mucosal CD4 cells, leading to a depletion of these lymphocytes, which usually are a barrier to typical infection from the gut, as a result of which it increases the susceptibility of the patient to bacterial, viral, all of the organisms because of the altered immune system. And in patients who have severe HIV, it contributes very much to the persistent diarrhea and malnutrition that can occur in this condition per se. All right, so that was a lot. The next phase of the presentation we're going to look specifically at diagnosis of HIV in children and adolescents. So HIV infection should be suspected under these infants and children in these circumstances. There's an unknown maternal HIV status at delivery, or there may be a history of maternal history of HIV infection. Mothers, adolescents who or children who present with a history of sexual abuse. All right. Children who present with symptoms or clinical conditions which are typical of HIV infection, including malnutrition as such. It's important in your review to review your perinatal history to determine if there's there's been a risk for maternal to child transmission of HIV. For those mothers who are known to have HIV and would have started antiretroviral therapy, you want to determine the risk of mother to child transmission. So it will involve, determining if and when the mother started antiretroviral therapy, if she's been adherent to the treatment. You want to look at any antenatal complications, because complications in pregnancy can increase the risk of transmission. Labor and delivery, things like the premature infant, prolonged rupture of membranes, prolonged labor, vaginal delivery and instrumentation increase the risk of transmission. If there's evidence of perinatal asphyxia, all right, and whether or not the infant had initiated antiretroviral prophylaxis, and certainly if the mother has been breastfeeding the child or not. All of these things would be important when you're considering the historical review of the patient. For an older child who you suspect may have HIV, the perinatal history is the same. You want to review in the same way to determine whether there's a risk for transmission, but you'd also want to consider behavioral risks, whether there has been forced or consensual sexual transmission risk. You want to review the patient's past medical history, whether there's been hospitalizations, recurrent infections, bacterial infections, recurrent diarrhea, recurrent ear infections, severe dermatitis, and the like. All right. If this patient had already been exposed to antiretroviral therapy, of course, you'd want to review the history of antiretroviral therapy. When it started, what regimes they were using, how adherent the patient has been, whether the patient has stopped treatment, if they've had any adverse effects of the treatment and the like, whether this patient has been linked to care and the like, if there's a family history of HIV infection, what social issues and barriers are there to treatment and care for the patient. All right. I'm going to skip these two slides. So in the evaluation of the patient, a patient who you suspect to have HIV or has probable HIV, at initiation, these are the things that you'd want to simply consider. But we talk about the medical history and examination already. You'd want to evaluate for the CD4 count, viral load, of course your CBC, your chemistry and liver function tests, your lipids, your blood glucose, all of the torch infections, and of course hepatitis B. And these are the typical things that we will do on initiation. There are others that we'll do if you decide to start the patient on antiretroviral therapy. Just to indicate to you that for patients who are HIV infected, the immunizations that they receive are typical for the patients, the non-HIV infected patients. In Jamaica, because we get BCG at birth, they would have already gotten it already as such. But the immunizations are very much the same. The only thing is that instead of the oral polio, we give the injectable polio instead, inactivated polio vaccine instead. And we strongly advocate that the patients should get the pneumococcal vaccine. All right. And for those patients who qualify, in other words, if the immune system is appropriate, then they should get the varicella vaccine per se. So, just to quickly look at the life cycle of the virus and how this relates to the treatment. So I'm not going to go through any details of it, but the virus attaches itself to the CD4 cells by specific receptors, CD4 receptors. And there are drugs to prevent this from occurring, which we don't have available to us in Jamaica. Okay? The virus envelope fuses with the CD4 cell and allows the genetic material to enter the CD4 cell. Again, there's drugs that can inhibit this fusion, which we don't have available to us in Jamaica. The first thing which occurs is you have the HIV viral RNA, which undergoes reverse transcriptase to double-stranded HIV DNA. So the drugs that we use to prevent this occurrence is the NRTIs and the NNRTIs, the non-nucleoside and the non-nucleoside and the nucleoside reverse transcriptase inhibitors. Okay, the genetic material is then integrated into the host cell nucleus. We have drugs called integrase inhibitors that prevent this occurring. Once the virus is integrated, the viral DNA is integrated in the host DNA, the host CD4 DNA, then it produces copies of the viral, genetic material of the virus, okay, as you can see here. And these are packaged in the cytoplasm with protein to produce viral particles. And we do have drugs that can prevent this packaging for the protease inhibitors as such. So it's a simple diagram showing, you know, based on the life cycle, how the antiretroviral drugs actually work and where they work. So very quickly, I'm not going to do all of the slides in the interest of time, but who do we treat and when do we when we start antiretroviral therapy? Well, we treat all children and adolescents as long as they've been diagnosed with HIV, regardless of what their stage is as such. This is the most updated recommendations, and this is what we follow in Jamaica. What we use is based on your age group, okay? For adolescents, we use, well, let's start with the neonates. So with the neonates, well, let's up to 3 years of age, we have a backbone of the NRTI. So everybody, a backbone of the NRTI, zidovudine and lamivudine, with either a nevirapine or a protease inhibitor. All right. And we tend to favor using a protease inhibitor because of the risk of nevirapine resistance due to transferred resistance from the mothers per se. All right. For older children, all right, we still use the same backbone, either zidovudine and lamivudine or abacavir and lamivudine with either nevirapine or efavirenz. And for adolescents, we use tenofovir and lamivudine with either dolutegravir, which is a integrase inhibitor, which is the preferred first-line treatment that we use here in Jamaica now. And the goal of treatment is maximal sustained viral suppression to undetectable levels. And ideally, what that means is less than 20 copies of the virus per mil after 6 months of treatment. For the WHO criteria is less than 1,000 copies per mil. Of course, adherence counseling is very important prior to and following antiretroviral treatment initiation. And if you start a patient on antiretroviral therapy, in the first 2 weeks, you want to monitor for intolerance. You want to ensure that the patient is adhering to it and if there are any acute adverse effects. Okay. 4 weeks after that, you want to follow up again to determine whether the patient is adhering to it and whether there are any adverse effects. And 6 to 8 weeks, you want to repeat the viral load. You want to check the viral load because you're expecting to see a significant reduction in the viral load. It's not going to be maximally suppressed, but you should see clear evidence that there is suppression of the virus as such. And again, you want to monitor for adverse effects and whether the patient is adhering to it. So this is what we hope for when we treat patients, what we expect to see, that once they initiate treatment, okay, what we expect is a significant reduction in their viral load to what you'd call undetectable levels, okay? And this will occur over time, and you expect that to occur, as long as the patient is taking the drug appropriately. And concomitant to that, you would see our improvement and restoration of the patient's immune system, i.e., an increase in the number of CD4 cells that the patient has over time, and that remains persistently so. This is what is hoped for, but it does not occur all the time. All right. I will share one more slide with you before I stop, just for you to realize that we do monitor the patients, and we have to monitor the patients because you want to determine whether or not your treatment is efficacious or not. All right. We use our viral load to monitor the patient, and if the criteria we use to determine that the treatment or the management is not working appropriately is what we call viral treatment failure. If you have a persistently detectable viral load greater than 1,000 copies, and where you have, what we do in practice is to do 2 consecutive viral load measurements within a 3-month period. And of course, in between that period, the patient is supported with counseling for adherence. And if despite all of that, the counseling and the adherence, the patient's viral load is still persistent, all right, then we can define that the patient is failing antiretroviral therapy. And if they're failing, then we have to change the regime as such. And if we have to change the regime, then we have to use a regime that is more robust and that will more likely be able to suppress the patient's viral copies per se. The things that normally cause treatment failure is if the patient is poorly adhering to the drugs, if there is ongoing development of resistance of the virus to the drug, and sometimes if the drug is too toxic for the patient to manage. These are the things that can cause treatment failure. All right. So I am going to stop right here. It's 11:53 minutes 33. You have another lecture, and if there are any questions, you can send me an email, and I will be able to discuss it with you. Thank you very much. I'm going to stop sharing this now.
Hello, good morning.
Good morning, Doc.
Okay, good. You just finished with Professor Pear, right?
Yeah, just finished.
Okay, so I am I'm just uploading. It says converting my slides to share.
Doc, could you
Yeah,
please
yes.
stop this recording and then start again
Sure,
when
no
you've
problem.
uploaded? Thanks.
Sure.